To me, there's no more effective system of care than the Ryan White care system. It provides for interdisciplinary, team-based care. Legitimately, some people say they do that, but the Ryan White care system actually does, where we have psychosocial team members and medical providers working collaboratively and effectively to help our patients. People involved in Ryan White achieve a rate of virologic suppression of 70%, compared to people who are not involved in Ryan White care, who on average achieve a rate of virologic suppression of 30%. But I think most importantly, we have to recognize that we are in a new era of the AIDS epidemic. Most people are not dying from HIV and AIDS. Most people are dying from preventable illnesses related to trauma, such as substance use, overdose, depression, suicide, heart, lung, and liver disease, and violence. And our goal is to awaken the Ryan White system to this reality and help build a better Ryan White system so that it can continue to be the beacon of care for AIDS in the world, as well as for other clinics taking care of conditions that aren't HIV but related to trauma. Changing a clinic to become trauma-informed does require funding. We received grants from 2 foundations to fund our initial effort to educate our staff and providers about the principles and practice of trauma-informed primary care. That included closing the clinic for 3 half-days and educating everyone from the janitor and frontline medical assistants to the providers and nurses about the impact of trauma on health and about trauma-informed practices that you could use immediately with patients. Subsequently, after those 3 bigger trainings, the trainers come back to our huddle, which is something that we have every week, 3 more times to deal with more practical issues that have arisen, like how do you deal with a patient who is very agitated, and how do you effectively de-escalate the situation in a way that is trauma-informed and compassionate. So far in our university-based health system, we haven't been able to increase billing to Medicaid for the increased services that we now have through trauma-informed primary care. Most of those services are administered through providers and through their provider interactions, but some are groups and specialized interventions administered by licensed clinical social workers and pharmacists. Hypothetically, those should be able to be billed, but within our university health system, it's been very hard to change it to allow for billing of those services. The benefits that we've seen since implementing trauma-informed care have been dramatic. We have seen patients who previously coped with trauma using substances be able to recover much more effectively from substance use. We've had patients reduce their isolation by joining trauma-informed support groups that we've developed, become much more comfortable with themselves, much less depressed, more able to engage their family and their children in healthful ways, go back to school. We've had patients re-engage in care, take their medicines more effectively. The impact, it's hard to overstate the impact of having services to address what I feel is the primary underlying issue faced by most of the women in clinic, which is trauma. We feel that the already fabulous interdisciplinary Ryan White primary care system can be improved dramatically in this new era by insinuating trauma-informed practices and services for patients so that they can not only survive HIV, but survive many of the other associated conditions that are harming them and killing them.